Hey, welcome back. Today we're going to go through the neuroscience of the midbrain. So the ventral surface is going to be composed of the cerebellar peduncle, the interpenducular fossa, and the rootlets of cranial nerve number 3, the ocular motor nerve. So right up here. The dorsal surface is going to be defined by the colliculi. So first is going to be made out of the tectum, the superior colliculi, the inferior colliculi, and then the trochlear nerve is going to wrap around. So cranial nerve number 3 is on the ventral side, dorsal side is cranial nerve number 4. There are 4 colliculi, the corporal quadrigemina, and there is the superior right here, the inferior, which is going to be trying to find it. Well, it was below the superior, so we're looking at the axial section. So below the superior colliculus would be the inferior colliculus, and then in between the two is the cruciform sulcus. So at this particular level, the most ventral side or dorsal side, so dorsal to ventral, is going to be the superior colliculus, and then the most lateral would be the medial geniculate nuclei. The most central, near the aqueduct sylvius, would be the ocular motor nuclei, so it's going to come out this way, along with the Edinger-Westphal nucleus more towards the center. And then the red nucleus is going to be beyond the medial longitudinal fasciculus, then the substantia nigra, and then most ventral would be the cerebellar peduncle. So we kind of went through all of that. The tectum is going to lie dorsal to the tegmentum and the cerebral aqueduct, and that's going to contain the nuclei of the superior and inferior colliculi. So cranial nerve number 3 is going to come out this way. Here's the cerebral aqueduct. Okay, so what is the crewcerebri, right? It's right here. And it is the basis pedunculus, so it's in between the superior and inferior colliculi. And this is orienting us towards the ventral side, because here the cranial nerve number 3 is coming out. The crewcerebri is the anterior portion of the cerebral peduncle, and it contains the motor tracts, and it will go from the cerebral cortex to the pons and the spine. So it's a relay station. Substantia nigra, it's called that because it's dark, and it's between the tegmentum and the cruce. It stretches from the cranial to the subthalamic region, and the concavity part is going to be the tegmentum, and the convexity part is going to be the crewcerebri. The dorsal part is going to be the pars compacta, which is where the cholinergic and the dopaminergic producing neurons are. Ventrally is going to be the pars reticularis, which is cell poor, and it's a major GABAergic neuron, so it's an inhibitory neuron. The substantia nigra, since it's a big component of producer of acetylcholine and dopamine, it's going to be shrunken in a person with Parkinson's. The superior colliculi is going to be in charge of integrating the visual, auditory, and somatosensory spatial information in order to orient the movements of the eyes and head. So this allows your vision to stay fixed even though you move your head, and the tracking movements as well. The fibers will come from the retina and to the optic radiation to the superior colliculi. The sensation, or the sensory or afferent neurons are going to come from the retinotactile fibers, and that's in charge of opening the pupil and the eye movements. And it also comes from the cortex and the spine as the cortical tactile fibers and the spinal tactile fibers. The efferents are going to be the tectospinal tract, the dorsal tegmental decussation of Marinette, the tectobulbar tract, the tectopontine tract, and the tectothalamic tract. So this is going to be important in proprioception, movement, or voluntary movement, involuntary movement. And then there's the decussation. The inferior colliculi is going to be your auditory path, and the afferent neurons are going to be from your lateral lemniscus. That's going to conduct the auditory impulses, and from the contralateral inferior colliculus through the commissural fibers to the ipsilateral medial geniculate body. So it comes right here, and it's going to be carried by the commissure fiber. The efferent is going to be your auditory integrating fibers and centers. So they go through the medial geniculate body nucleus and then it goes to the auditory sensory cortex in order to be integrated. And these are going to decussate opposite the inferior and ipsilateral to the superior colliculi. It also connects to the cerebellum, and it goes through the superior olivary nucleus, which functions as a relay station for the for the auditory pathway, and is concerned with the reflex, which is when you hear a noise like somewhat behind you or out of your vision, you don't know what's making that noise, you will tilt your head to hear it better. Okay, so at the periductal gray matter, the trochlear nerve is going to wrap around and cross at the superior medullary velum and then emerge below the inferior colliculi. The mesencephalic neuron of cranial nerve number 5 is going to be your lateral part of the central gray matter. Then the nucleus of the inferior colliculus, substantia nigra, and the reticular formation. And at the white matter, the superior cerebellar and the ascending tracts are going to make it up. The ventral tegmentum will cross to the subthalamic region, and the dorsal tegmentum decussates of Maynard. It's going to be where the nuclear complex of cranial nerve number 3 is, along with the motor nuclear of the extraocular muscles, the Edinger-Westphal nucleus, which is right here. Right here is going to be your red nucleus. It's always good to know where the red nucleus is because it does help you orientate yourself. And all of these work together to constrict the pupil and control the accommodation. Okay, so what is the red nucleus? It's made out of 2 parts. This is made out of large cells. This is made out of small cells, and it passes from the cerebellum to the rubrospinal tract, and it's the alternative path to the pyramidal tract, and this is concerned with input of information. Like I said, it relays impulses from the cerebral cortex and the cerebellum to the thalamus and the spinal cord via the rubrospinal tract. And it starts in the midbrain and then has to decussate before going through the medulla and the pons. The red nucleus will integrate with the cerebral cortex, help with the cerebellar processing. So this is important to the flexor and extensor neurons in order to maintain balance. Okay, so the efferent the component is going to cross to the ventral tegmentum, which is the decussation of Forel. The rubrospinal tract from the caudal part of the red nucleus to the entire spinal cord is going to be the output. It's going to control the contralateral flexor muscle tone, and the rubobulbar tract is going to be concerned with cranial nerves number 4 and 7, so the trochlear and the facial nerve. The rubro-olivary tract is going to be your feedback system to control like coordination and posture and proprioception. And then the rubrothalamic fibers will go to the ventral lateral nucleus. The medial longitudinal fasciculus appears as white because it's heavily myelinated. It extends cranially to the interstitial nucleus of Cagel, which is going to be your accessory ocular motor nerve. So it's going to deal with something with the eyes. It's connected to the visual nucleus and the spinal nucleus of cranial nerve number 11, along with the anterior horn cells of the spinal cord. It coordinates the movement of the eyes and necks in response to the vestibular cochlear nerve. So in this, it allows you to tilt your head and keep your vision like standing straight up. The important part here is like the basilar artery. Any kind of infarction is going to heavily affect the midbrain. Everything's going to be drained by the great cerebral and the basilar vein. Okay, so Weber syndrome is the occlusion of the post-cerebral artery, and it's going to affect the fascicle and the cerebral peduncle. It's going to cause an ipsilateral squint because of the cranial nerve 3 involvement. Contralateral hemiplegia because remember there's a decussation above the medulla. So that's the corticospinal tract. Contralateral paralysis, kind of same thing. It decussates above the medulla. So it's responsible for, the cortical bulbar tract in the crewcerebri is going to be responsible for that. It's going to be one of the signs. It's not really defined, but one of the signs is the drooping of the upper eyelid, and what's more specific is the pupil is dilated and fixed to light. So there's a problem with the Edinger-Westphal nucleus. So even when the light is shown in the patient's eye, it won't constrict. So accommodation is lost on the side of lesion, and the eye is going to be like pointing down and out on the side of the lesion. So in this case, let's see. We're going to say this is the dorsal, this is the ventral side. So we're looking at this, and this would be the left side of the spinal cord. So in the patient's left eye will be looking down and out. Okay, so Benedict syndrome is going to be occlusion of the paramedian branch of the posterior cerebral artery. So there's going to be an ischemia of the tegmentum midbrain. So it's going to be affected right here. What's this big bump here? It's going to be the red nucleus. So midbrain, red nucleus, and cranial nerve number 3, because cranial nerve number 3 comes out this way, right? Those things are going to be affected, and it's going to manifest as a ipsilateral squint and ptosis. There's going to be a contralateral loss of pain and temperature due to the trigeminal and the spinal lemniscus involvement. There's going to be a contralateral loss of 2-point discrimination thanks to the medial lemniscus, so it's around this area. And you're also going to lose the muscular joint and vibratory sense. The contralateral tremor and the involuntary movement in the limbs is due to the red nucleus. So here is the different strokes, and this is a summary. So Weber syndrome, there's the crewcerebri, midbrain. Benedict is kind of like a combination of both. Paranose or Paranod syndrome is going to be the tumor of the pineal gland, and that compresses the superior colliculus. So superior eyes, inferior auditory. So eyes are going to be affected. It can be caused by stroke, multiple sclerosis, and hydrocephalus. And clues is your mnemonic. There's going to be convergence retraction or nystagmus. Light near dissociation, so pupillary reflex is going to be absent. the upward gaze paralysis. So they are going to be always looking up, and eyelid retraction. There's problems with blinking and skew deviation. So an eye is going to be like down and out or up and out. Okay, the Argyll-Robinson pupil is going to be a lesion in the pretectal nucleus. The light reflex is lost, so their eyes are not going to respond to a light. It's not going to constrict, but the eye muscles themselves are going to be intact, so accommodation is possible. That's it for now. Thank you for your attention and good luck studying.